Welcome. Today we are going to learn when to do a closed reduction and internal fixation for a distal end radius fracture. This is Abraham Cooley, who was a great surgeon and a very famous anatomist who hailed from Ireland, who has to his name a fascia, a ligament, a fracture, which is synonymous with his name. The beauty of his work that he had published in the early 19th century was that he had described this fracture, which was sustained by fall on an outstretched hand. By looking at the deformities, he had described the displacements of the fracture, and because of this dinner fork deformity that the patients usually present with, that resembles that of a dinner fork, he had correctly described the displacement of the fragments. But astonishing thing was that he didn't had X-ray to his disposals. Uh, the X-rays were discovered 80 years after Abraham Cooley's had described this fracture. Now, in order to understand the distal and radius fractures, we need help of X-rays. Now, X-rays can be PA and lateral views. We usually need two views. In addition, we may add an oblique view. Now, CT scan has revolutionized the understanding of fracture fragments, especially for the periarticular and the intraarticular subgroups. And then MRI and arthroscopy can also aid in the diagnosis of distal and radius fracture. Now, there are a lot many methods of treating this. That can range from a simple cast to K wires, external fixators, hybrid fixation involving the fixator as well as K wires. This is Joshi's external stabilization system, the Jess fixator and K wires. This is a Herbert screw for scaphoid. Then we have a lot of plate designs. There are more than 40 designs of the plates that are available for distal radius fracture. We have the volar plates, we have the dorsal plates, we have the locking and non-locking plates. So we have a lot of options to choose from when it comes to plating. Then we have the rim plates. Then also we have the new kid in the block, which is an intramedullary nail for radius. So having a lot many options, it makes us it creates a lot of confusion in the mind of an orthopedician. Now, in order to clear certain things, the British Orthopedic Association and the British Society for Surgery of the Hand, they collaborated to commission a committee to produce the best practice guidelines on the management of distal radial fractures. So they published this book in 2018, and which was taking into consideration all the literature that was published all around the world, and they came to this thing. They gave a recommendation that there is no evidence supporting any treatment option for patients who are less than 50 years of age and up to 65 years of age. So there is no clear cut evidence to support for any treatment options for the patients. So other thing that this book described was that in patients who are more than 65 years of age, there is evidence that operative intervention does not provide a superior outcome to non-operative management when measured by patient-related outcome measures at 1 year. The reason being is that people who are more than 65 years of age, their acceptability is more the malunion that a patient would have. The acceptability is more in patients who are above this age group. A similar thing was noticed by the American Academy of Orthopedic Surgeons, who also found that there's strong evidence suggesting that operative treatment for geriatric patients that can be defined as 65 years of age and more does not lead to improved long-term patients. Operative treatment for geriatric patient does not lead to improved long-term patient reported outcomes compared to non-operative outcomes. So let's see how to proceed. parameters. So the first of all, the thing that we are going to learn is about radial height. So first of all, a long axis is drawn along the long axis. A line is drawn along the long axis of the radius, and a line is drawn which is perpendicular to this long axis, touching the tip of the radial styloid. Now, a second line is drawn perpendicular to this long axis, which connects the central reference point to the long axis of the radius. And the difference between the difference between the two lines will be the radial height. Now, in order to remember a number, it is taken. The radial height is usually on an average is taken as 13 millimeters. Now, for radial inclination, again draw a long axis of the radius and draw a perpendicular line to the central reference point, and then again draw a line connecting the central reference point and the radial styloid like this. So we get an angle here which we call as the radial inclination, and this angle is somewhere between 23 degrees. Now for volar tilt, this angle is calculated in the lateral view, and for that we will draw the long axis of the radius and we'll draw a perpendicular touching the dorsal tip of the distal articular surface of radius, and another line which is touching uh, the the dorsal and the volar articular surface of the distal radius. So here the angle that is made is the volar tilt, and it is around 11 degrees. Now this article was published in the Journal of Hand Surgeries and Journal of Hand Surgery, where the authors did a biomechanical study of the distal radial fractures, and they found a very interesting observation that when the palmar tilt changed from 10 degrees to 45 degrees of dorsal tilt like this in this X-ray, they found that the normal load that passed through the ulna, which was around 21%, it increased to 67% of the total load. So this parameters that we had learned shows the importance of these parameters, that how a change in the volar tilt, it changes the biomechanics of the wrist. So the CT scan has revolutionized uh, the concept of understanding for periarticular intraarticular fractures. Now, in order to calculate the articular step, we can easily calculate it on the CT scan. So, for example, this will be place where the distal radius will be, and this will be the intraarticular step off. So now this article was published in the Journal of JBJS, and here the authors tried to find they tried to find out whether the radiographic measurements of the displacement of the distal radius fractures are reliable and reproducible, and out of all the parameters, they all agreed that volar tilt was something that had the maximum inter-observer correlation, followed by radial height and radial inclination. So intra-articular step, intra-articular gap was the least, and there was a lot of inter-observer, uh, intra and inter-observer. This thing, they were not reproducible. So the most important reproducible parameter for distal and radius was volar tilt, followed by radial height. Now, this remarkable landmark paper was published in the year 1989 in the Injury Journal, and LaFontaine gave a criteria regarding surgery for distal and radius fractures. According to him, if there's a dorsal degree of more than 20 degrees, dorsal comminution, an intra-articular fracture, an associated ulnar fracture, and if the age is more than 60 years, so if there are more than three or more than three of the following five, then surgical intervention is required. Now, if this question might have come to your mind, that out of all the radiographic parameters, which affect the functional outcome the most? So a Delphi study group was constituted. In this, around 43 surgeons were included in the study, which included hand and wrist specialists, trauma surgeons, and international researchers. So they were given questionnaires, and according to them, it was found that for extra-articular fractures, it was the ulnar variance and dorsal tilt that these experts found to be of utmost importance when it came to the functional outcome. For intra-articular fracture, it was the intra-articular step. So, accordingly, the Delphi group for the extra-articular fractures, they found that in an age group of 38, 58, and 75, they were in a strong agreement for ulnar variance in the age group of 38 and 58. For ulnar variance, that will be 3 mm. But there was some disagreement between them in the age group of 75, where few people said it is 4, or few people said that it is more than 5 mm. So dorsal tilt was anything more than 10 degrees was not was having a bad functional outcome in the age group of 38 and 58. In elderlies, it went up to 75%. Now, for the intra-articular fractures, it is the intra-articular step. For 38 and 58, it was 2 mm, and for more than 75 years of age group, that was around 3 mm. So once we open our books, we find a lot many classification for the distal and radius fractures, and it becomes a lot of confusion. So what I personally like is that of Cooney's or universal classification, which can be classified as extra-articular and intra-articular fractures. The extra-articular fracture could be either non-displaced or displaced, and the intra-articular fractures can also be classified as non-displaced and displaced. They can further be sub-classified as reducible and stable, reducible and unstable, and irreducible. So it is the classification as these class. There are a lot many classification. It becomes very confusing for the students. So Fernandez gave the classification based on the mechanism of injury. The type 1 will be bending fractures of the metaphysis that constitutes your Cooley's fracture, the dorsal displacement and volar, that is the Smith's fracture. Then the type 2 will be shearing fracture of the distal and radius, that would involve the volar Barton and the dorsal Barton. The type 3 will be compression fracture of the joint surface. Type 4 will be avulsion fractures and radiocarpal fracture dislocations. Type 5 will be combined fractures, that is seen in high velocity injuries. The other classification is the Frickman classification. The Frickman classification also involves involvement of the ulnar styloid, and for all the odd fractures, they don't have an ulnar styloid fracture, while as the even fractures are having the ulnar styloid fractures. So that could be extra-articular and intra-articular fractures. Now Malone gave a classification for intra-articular fractures. That's a very complicated one, and it becomes very difficult to understand and remember and recapitulate. The AO classification is other classification that is very exhaustive and is difficult to retain and remember. So in distal and radius fractures, the classifications, they don't work. The reason being that none of these classification systems, they show substantial inter-observer agreement. They cannot be reproduced, and they do not correlate with the outcome. So now what do we do? How to make a decision for the distal and radius fracture? Now there are a lot of patient-specific factors that we have to keep in our mind. What is the mental, and that too also it is important in this following priority: the mental capacity of the patient, what is his function, what are the medical comorbidities, his age, compliance with rehabilitation, the occupation of patient, fragility, his dominant side or not, and associated other injuries. Now then there are surgeon related factors. What is the surgeon's choice, his acceptability and availability of implants, experience of the surgeon and the learning curve. Then fracture related factors, there are the anatomy and comminution, whether the fracture is closed or compound, whether it is displaced or undisplaced, whether it is an extra-articular or intra-articular fracture, whether it is reducible or irreducible, whether it is stable or unstable, and associated distal radial ulnar joint and the distal neurovascular status. So getting a lot of information would cause us to be something like this. So we are lost. So now, how to proceed and manage patients with distal and radius fractures? So remember, what are we trying to prevent? When we think from a surgeon's perspective, we think of we are trying to prevent malunion, shortening, joint incongruity, and osteoarthritis. From a patient's perspective, he doesn't want to have pain. He wants a good function of his hand. He doesn't want to have a residual weakness, and the appearance of the hand should be good. Now, what do you mean by fracture personality? Now, whenever a distal and radius fracture comes to the ER or your OPD, we have to answer the following questions. Number one, whether the fracture is displaced or undisplaced. Number second, whether it is intra-articular or extra-articular. Number three, whether it is reducible or irreducible. And number four, whether it is stable or unstable. So this is the most important slide of my talk. If you are able to understand and remember this slide, I think you will understand the topic well. So I repeat, so whenever you find a distal and radius fractures, try to answer these four questions: whether it is displaced or not, whether it is intra-articular or extra-articular, whether it is reducible or irreducible, and whether it is stable or unstable. So this is an algorithm that I have tried to make, and this is the most simplified version of the algorithms for management of distal and radius fractures. So I have classified it as number one, displaced and undisplaced. If it is an undisplaced fracture of the distal and radius, irrespective of the fact that it is whether it is intra-articular or extra-articular, we have to put in a cast, and there will be weekly follow-ups for 3 weeks. Now, if the distal and radius fracture is displaced, then we have to make out whether it is reducible or non-reducible. If it is reducible and stable, then we again put a cast and weekly follow-up for 3 weeks. If it is unstable, we have to do closed reduction, internal fixation. If it is non-reducible, we have to do open reduction and internal fixation. So the various forms for non-operative treatment are a simple uh, Cooley's cast, or the below elbow POP cast, or a fiber cast that we can given. So in whom we have to give this cast? For all undisplaced fractures, for displaced extra-articular fractures which are reducible and stable, and patients who are more than 65 years of age. So it is seen that unstable in patients who are more than 65, even unstable fractures can be managed conservatively in a cast in some low demand patient, because uh, their tolerance of they have high tolerance for malunion. So the idea is to put this cast for 4 weeks, and we have to get a weekly follow-up x-rays for the first 3 weeks. Now, for example, this is a patient who had a dorsally displaced fracture of extra-articular fracture of the distal and radius with ulnar styloid fracture, which is a Frickman type B. So initially there was a lot of swelling, so I reduced it and applied a slab, a below elbow slab, and converted into a cast. These are the serial x-rays of the patient after 1 week and after 2 weeks, and this is the final x-ray of the patient. The radius has united well, and also the ulnar styloid, and the parameters are intact. This is the lateral view. This is an x-ray taken after 1 year of the cast. So now, when to do surgery? It is important that if the fracture is irreducible and unstable, we have to do a surgery. For bilateral fractures, we have to do surgery. Compound fractures, we need to do surgeries. Polytrauma patient and secondary displacement after casting. So what are the operative options that we have? We have a percutaneous pinning, means where we can put K wires across the fracture site. We can do an external fixation, like this will be a trans-articular external fixator, and internal fixation in the form of volar plates, and hybrid fixations in which we put combine two modalities like a fixator and a K-wire. So again, from this book of the best practice for management of distal radius fractures, there is 11 1+ evidence where they have said for a dorsally displaced reducible fracture, for this is the most important thing, for a dorsally displaced reducible distal radial fracture requiring surgery. So please understand and pay attention that this is a dorsally displaced reducible distal radial fractures which require surgeries. Then they have said that open reduction internal fixation is not superior to K-wire fixation when measured by patient-related outcome measures at 1 year. So many people they don't understand this line. So they say that dorsally displaced reducible distal radial fractures that require surgery. It doesn't include the high velocity injuries and the intra-articular fractures which are irreducible and all. So this is dorsally displaced reducible distal radial fractures requiring surgery. For them, open reduction internal fixation is not superior to K-wire fixation at 1 year when measured by patient-related outcome measures. So their recommendation, they had a grade A recommendation that when surgery is needed for dorsally displaced distal radial fractures that can be reduced closed, offer a closed reduction internal fixation with a K-wire and cast. So this is the most important, again, this is the second most important slide of my talk, and if you understand this slide, I think my job is done. So please, I'll repeat, whenever a surgery is required for a dorsally displaced distal radial distal radius fracture that can be reduced closed, offer him closed reduction internal fixation with a K-wire and a cast. So we have to know certain principles that so in other way how to put it as so in whom to do closed reduction internal fixation will be young patients with reducible distal and radius fractures, dorsally displaced reducible fractures with instability, and the radial shortening more than 5 mm, radial inclination less than 15, dorsal tilt of more than 10, ulnar variance of more than 2 mm, and intra-articular step of more than 2 mm. In age more than 65 years of age, the patients have acceptable functional outcome and treatment satisfaction despite malunion. So the principle is to achieve reduction, maintain reduction, and early rehabilitation. Now there are a lot of ways by which we can do the K-wire fixation or pinning. We have the extrafocal, that will be a pure transtyloid radial. Then we have the transtyloid and the dorsal radial, and we have the transtyloid and the ulnoradial pinning. These are the three form of pinnings that we no, then we have the intrafocal pinning that was made famous by Kapanji. He introduced a K-wire from the dorsal side into the fracture side, and he levered it across and across the fracture site, and he pulled the lever down, the K-wire down, thereby reducing the displaced dorsal fracture. And once the fracture reduction was achieved, he used to drive the K-wire into the distal cortex. So this intrafocal K-wire, we can have one or two intrafocal K-wires which can be supplemented by otherwise. So this intrafocal K-wires technique is also there. So this is the reduction technique that was given by um, John Chanley in his book of close reduction method. So this is what is usually told to us, that the dorsal periosteum and soft tissue envelope is intact, but it is kinked. Here the fracture fragment is the distal fragment is displaced dorsally, and what we have to do is we have to give a linear traction, and we have to reduce it by keeping this the dorsal soft tissue hinge intact. So by making use of this dorsal, we have to straighten the dorsal intact soft tissue hinge, we can achieve the reduction. So when we do a pinning, we see a lot of nerves at the tip of the radial styloid, and which can be injured will be the superficial branch of the radial nerve. So it is imperative that we give an incision distal to the tip of the radial styloid around 2 to 3 centimeters, dissect the soft tissue, and we have to be careful of not involving the nerve and put a soft tissue sleeve, and through it we put our K-wires. So this is how we the other wire that we have to do will be between fourth and fifth extensor tendon, and this will help us in achieving a crossed K-wire configuration. And This is what is recommended. Other people would like to go through the Lister's tubercle, but then there is an injury, the chance of injury to there's a chance of rupturing the extensor tendon. So, Mr. Abraham Cooley's famous lines, he said that only consolation that remains that the limb will, at some remote period, again enjoys perfect freedom in all its motion and be completely exempt from pain. The deformity, however, will remain undiminished through life. So, this completely and undiminished through life is something. So the take-home messages from my presentation are that there is no clear consensus on the management of distal and radius fractures. The goal of our treatment will be to restore congruity of the radiocarpal joint and the distal radioulnar joint surfaces, and to restore and maintain the length of the radius. Osteosynthesis using K-wire fixation is a reliable procedure for dorsally displaced distal and radius fractures that cannot be stabilized by casting. It may be indicated for certain type of intra-articular fractures and has advantages over plating in terms of cost and invasiveness. I hope you liked the video. If you did, kindly like, share, subscribe and comment. Thanks for watching.